Ravindra, please take us back to OT-1.
Yeah. So we are getting ready for the procedure.
Sir, there is a question from the delegate side. As there is an element of myelopathy in the patient, so what is your final plan?
So basically, there is no major neurological deficit, even if the MRI is showing a little bit of myelopathy.
Yes, sir.
The basic problem is that patient is having radiating pain.
Yes, sir.
And if good neurological examination has told us that there is no major motor deficit.
Okay,
so
sir.
first we control the pain, and then we take a call on what else to be done. So
Okay,
for this patient, since you have seen the MRI, there are two discs which are bulging, L4-5 and L5-S1, and she has a radicular pain. Which side?
Yeah,
Left
we
side.
understood that as patient is having predominant lower limb symptoms, that's why we are going ahead with the our plan of root block.
Root block, yes.
Sir, we have another question from the audience.
Ji.
People are saying, so what is the cutoff defined? Like L4, L5, there is a disc which is quite prolapsed.
Yeah.
So what is the surgical indication, and where do we
See,
go
basically
for
the
pain
surgical
management?
indication comes with your neurological examination. If there is a sensory deficit, we still go ahead with the blocks. But if there is a motor deficit, that is definitely no. So if there are motor deficit, cauda equina, muscle wasting, then definitely we go for surgery.
So
But
what
if
about, sir, Shantanu has a question.
can I speak?
Sir, are we delaying just an inevitable process? Because if the patient comes to me and if I give the option of a block and a surgery, he will definitely go for a block.
Yeah.
But I think we may be delaying his inevitable that he may end up in surgery after a few years. So is it good for the patient?
No, it is. I mean, as I said, actually we just saw the patient now, but definitely the patient doesn't have any motor deficit. She just complains of pain. So even if you do,
is it necessary to wait for the motor deficit to happen and then go for surgery?
Absolutely no. If you think that it's an impending deficit, if the patient's disc is so much bulged that it is going to cause her motor deficit later on, I think surgery would be the option. Definitely surgery would be the option.
I would like to summarize. In this patient, there are two things. One is element of cervical myelopathy plus acute radicular pain. Pain is a thing which we can manage very quickly. Maybe by afternoon he should be pain free.
Yeah.
But surgery will require planning, admission, anesthesia checkup. That all takes time. So by the time he makes the patient is prepared for surgery, he can have pain relief by this foraminal block. I think there is no dilemma in. The only thing is we need to be careful while positioning this patient so that we don't exacerbate the disc prolapse of the cervical lesion. C5-6 PIVD should not get exacerbated. We should take all precautions while turning the patient prone.
Shekhar, S1 foramen.
Ravindra, can you show us the operative area?
S1 foramen. Shekhar, can I see this S1 foramen?
Ravindra, can you focus your camera on the screen on the patient? OT-1, please focus on OT-1 as the process is going on there.
आप दिखा रहे हैं पेशेंट को और वो उसका भी आपके पास है?
Yes sir, OT-1 you are connected sir.
No, we are seeing OT-2.
आप S1 दिखा रहे हैं?
Yeah. Now it's fine.
जी. सीएम चलाने वाला कोई है? नहीं, ये तो मेरा बंदा है ना. देखो सुनो, ये है S1 देखा. So basically we are going to first demonstrate to you the S1 root block, and for the S1 root block आप zoom out करके दिखाइए सीएम. So the CM has to be in a coordinate direction. मुझे foot pedal तो चाहिए होगा ना? Anybody who can handle this CM and give me the foot pedal. So these patients are generally done under sedation. So we give 1 or 2 milligrams of midazolam, and if the patient is very apprehensive and got a lot of pain, then you add some fentanyl also, 25 to 50. So that means you need to do it in the operation theater set up with all the resuscitation facilities and possibly an anesthesiologist in attendance.
Sir, then do you ask the patient to be NPO or
we generally ask the patient to be 3 hours NPO. Please shoot, please.
Okay, sir.
So we are trying to identify the S1 foramen. Shoot, please. और थोड़ा सा ले जाइए कॉर्डेड आपको C1
Sir, delegates wants to know your entry point, how you from where you will enter.
जी आई एम जस्ट गोइंग टू टेल
Yeah.
जब वी आर पोजिशनिंग द C arm shoot please shoot shoot please we are doing the left side no? Shoot. So that's the place where S1 foramen, you can see the opening of the shoot please. Yeah, so now shoot please. So that's the place where the S1 foramen lies, right?
Yes, sir.
And I'm going to give some local anesthesia there. सुन कर रहे हैं. Have you given some sedation? Some fentanyl also? एक और दे दो.
Sir, have we already given some sedation to the patient
Yeah,
or
2
no?
milligram of midazolam has been given.
Okay, sir.
Yeah. So we use a spinal needle.
Sir, can you delegates wants to know the needle size you are using for this?
22 gauge 10 centimeter spinal needle.
Yes, sir.
And you see I am going to just bend the tip of the needle a little bit.
Yes, sir.
Zoom करिए.
Sir, some needles are there with curved tip also. I have given curved tip needles also to the OT. You
ठीक
can
है,
use them also.
I'll check that. So we have just bent it so that the tip of the needle is in my view. So I just check the position of the needle with the tip, right? So after,
Yes, sir.
after waiting for a couple of minutes, after giving local anesthesia, you insert the needle in the direction of the C arm. Shoot please. So that the direction of the C arm is important. Check please. Check please. टांग में क्या क्या ठीक है. So once you are in position, you can इसको lateral में कर सकते हैं. Please shoot, please shoot. Shoot. So can we check in the lateral position, please? So as Dr. Dhruv said that you have to confirm in 2 positions. So this was a corded AP view, and now we're going to check in the lateral view. So you can see whether the needle is in the foramen or not.
Yes, sir.
Lateral view, please. Table up, please. Yeah. So I mean, you have to be your own radiographer because very few people will understand the intricacies of. So you.
Yes, sir. We understand this. Everything is in angles here.
Yeah.
So even if tilt of 1 or 2 degrees creates problems in this.
So you can now check the lateral view, and you can see the position of the needle. So next comes the confirmation.
What you are injecting, sir?
This is dye Omnipec 300. So as check please, shoot please. Yeah.
And is it diluted?
No, it is not diluted.
Okay, sir.
It is concentrated, and you now see please check the lateral view. So you can see the nerve, and then you make it again AP view to check whether you are in the right position.
Sir, वो along the nerve ही जा रहा है.
Right. So now we are again going in AP and सीधा करिए और shoot please. So that's the route. You can beautifully see the S1 route. Is that very clear to everyone?
Yes, sir. It's very well seen, sir.
And you can see a beautiful route, and the dye is spreading right up to L5.
Yes, sir.
I put some more dye, and you can see even the L5 area is covered. Just for academic interest, I am putting this. Yeah. So once you put this dye, check. Now you can see it's going right up to L5. So that's the time when you have to give the drug. So we have triamcinolone. You have triamcinolone. This is 80 milligram. Yeah. So we will be giving 20 milligram at each route. Right?
Sir, how much amount of dye you have injected?
we have injected about less than 1 ml, 0.5 ml of dye.
Okay, sir.
And you can see a beautiful spread with 0.5 ml of the dye. Right?
Yes, sir.
So we now give the drug. So I will be giving about
Sir, delegates wants to know what drug you are injecting and dose and amount, how
So
much
this is
you are.
triamcinolone, and we are injecting about 20 milligram at each side. So when you inject it, it's a bit irritant. That's why we put some local anesthetic, like the local anesthetic which does not have preservative. We inject it over there. Little painful. Can you show the C-arm again, please? C-arm again. C-arm, yeah. You can see the good spread now. Beautifully, the nerve has been outlined, and the entire S1 route is clearly seen, right, going up to the L5. So 20 milligrams of triamcinolone at this particular juncture. And this is a very important component of spinal intervention, the S1 route, because most often in L5 S1 disc, it is the exiting S1 route which causes more symptoms. Patient complains of pain on sitting. So this has a very dramatic effect, and within a period of 48 to 72 hours, patient starts getting relief, although the actual relief will come after 1 to 2 weeks. So that we complete the S1 route. Now we go to L5.
Sir, when you are injecting the steroid, does it also have some contrast in it?
No. Contrast is only given early in the first stage. नहीं रहने दे अभी ये वाला केस कर लो.
Sir, delegates wants to know about the possibility of any allergic reactions to these medicines and how to prevent them.
See, basically, Omnipaque which you are using is a non-ionic dye.
Yes,
it
sir.
has zero incidence of any untoward side effect.
Ji, sir.
So which
So
drug
basically,
you have
you pardon me.
Which drug?
We use triamcinolone.
Okay.
Triamcinolone is
How-
more or less a non-particulate steroid, and it has a longer duration of effect.
So how much what dose?
20 milligrams.
Okay. And does it depend upon
Yet
the level
other-
of the
yet
injection?
other-
Or
Pardon? Say it again.
does the dose depend upon the level of the injection where we are injecting?
No. Dose depends on each nerve route. So we are going to target 3 routes now, S1, L5 and L4. So total dose of about 60 to 80 milligram is one which we prefer.
Sir, one question.
60 to 80 milligram for one patient or for one
For
route,
one
sir?
patient for 3 routes. So 20 milligram at each
per
route.
And 60
Sir, can
milligram.
you show us the position of APV for S1, sir? Like what
it
caudal,
is-
how many degrees should be tilted?
The degree of tilt has to be depending upon what you see there. So you don't have a predefined degree. You have to see the foramen. So at whatever level you see it, maybe 30 degree, 40 degree, you go for it. So now we are going for a L5.
So that means your technician, CM technician should be equally competent and well trained.
Yes, definitely. That's why I brought my own technician, Shekhar.
Thanks to you, sir.
Yeah, I think we should applaud Shekhar. He's with me.
I think Shekhar is there with you for
Yeah.
doing all
Yeah.
this work for you.
He's with me for last quarter a century now.
Yes, sir. Thank you, Shekhar. Thank you so much.
Sir, do you use dexamethasone for injecting?
I personally don't use.
Thank you.
But yeah, there are reports of
So
it.
now which level are you
Now we are
showing,
going at L5. Please show it again.
So
Please
you
shoot
block
now.
all the levels where there's a disc prolapse, or you try to
No,
fix it?
because this patient has 2 level disc prolapse. The exiting routes at the L4-5 level and L5-S1 level are, you go by the MRI, you go by the patient's symptoms. So it is not just that I am deciding because there are 2 discs. थोड़ा सा और lateral करना.
Sir, delegates wants to know there are 3-4 steroids available like hydrocort, dexamethasone, methylprednisolone.
So we
How
use-
to use and how to decide that which steroid should be used for
So
this?
basically you have to use the depot preparation, and amongst the depot preparation we have depomedrol, which is methylprednisolone. You have triamcinolone, which is like Canacort or Tricort, which you would have heard.
That
The-
means we can use both
Yes,
depomedrol or this
Either.
Kinacort,
Yes.
both.
But these are like dexamethasone, betamethasone are being used. They are non-particulate, but they are not depot preparations. थोड़ा सा और जाना शायद नीचे end plate. Now we are trying to square off the inferior end plate of L5. So he is tilting it little corded. So
Professor Bindra, can you comment on this steroids?
Let him explain.
essentially steroids are your choice basically. So whatever you are comfortable with. I am using it for last 40 years, the methylprednisolone and triamcinolone, so I am comfortable and over the years, thousands of patients, yeah. So now just please show it again. Show it again, please. Show it again, please. Show. So we are squaring it and just करो ना यार, या तो मुझे दो या करो खुद. Zoom नहीं यार, थोड़ा अपनी तरफ ले जाओ. सेंटर करिए. अरे इसको मत खींचिए. हाँ सेंटर दिखाओ. Show me. हाँ ठीक है. So can you see now? मेरे को foot pedal दे दो यार. I'm depending on you. So I generally use the foot pedal to shoot myself. Show please. I don't call this shoot. So now you can see the foramen, infraneural approach just below the pedicle. If you can zoom it, everybody can see it better. So I'm giving some local anesthetic. Can you give one more midazolam, please? Local anesthetic. More local anesthetic, please. Local anesthetic. Sister?
Puranjay, you can give the CM pedal to sir, if sir is comfortable with that.
I hate to call shoot.
Yeah, I understand, sir.
So this is the Scotty dog view, sir. We are
Yes,
seeing.
this is the Scotty dog view. You can see the ears. एक मिनट मैं बताता हूँ. Just give me some time. Dr. Dhruv, can you just show that? अच्छा ठीक है. So I'll just show you. ठीक है, मैं दिखाता हूँ. Shoot, please shoot. So this is the ear of the. वहाँ से जाने का फायदा नहीं है. This is the face of the Scotty dog.
Yes.
And I'm at just shoot please. I'm at this shoot. Yeah, this is the eye.
Right.
Yeah. यहाँ पे आने से आ जाएगा. हाँ ठीक है. फिर shoot please shoot. मैं कुछ नहीं कर रहा. Proceed.
So have you tilted the patient, sir, little bit?
So that this is the ear of the Scotty dog, which is the superior articular process.
Right.
Then in between is this is the pedicle, and this is the eye of the Scotty dog. Then you have the facet joint. This is the facet joint, and then we have the inferior articular process.
Ravinder, you are out of focus.
Please do not move the camera when sir is showing.
Yeah,
Then
please.
we have the
Yeah.
inferior articular
Can you repeat,
process.
sir?
Yeah, so we have the superior articular process as he is outlining. Then below is the pedicle, and the eye of the Scotty dog is one where the medial branch is. Then you have the complete face of the dog, and below the dog you can see a needle wherein we are going into the foramen. So that's the foramen. And then you have the facet joint, Dr. Dhruv, facet joint. That's the facet joint, and by the medial side of the facet joint is the inferior articular process of the upper vertebra. So my needle, you can see presently is just below the pedicle at the 6 o'clock position. Now I'm shoot please. Yeah. So I'm going to change the direction to the infraneural. Show please. Check please. Shoot. 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 So you have to go very gently into the foramen because
Sir, this needle which you are using to just put the local,
no, this needle is going
this
into
is the spinal needle, sir.
No, this is the spinal needle, not local. Local has already been given. AP, please. So we'll go in the lateral view to see whether we inside. First the AP view. Shoot, please, shoot. So then you see the lateral recess. Yes. Now you can see the lateral recess. Maybe I have to go a little bit in now. Yeah. So that's it. So that's my final point in the lateral view. Now I will check in the AP view. Now I'm going to check in the lateral view whether I am inside the foramen and what distance I am in the foramen so that I am not touching the nerve.
Sir,
It appears, yeah.
Just for confidence level, how much of the needle should be inside and how much should be outside for
See,
tension?
that you cannot describe by, I mean, like by millimeters and centimeters, but you have to be just at the mouth of the foramen. The lateral recess you can see.
Yes.
That's the lateral recess, so you have to be just there. If I go a little bit in, I am going to touch the nerve, which would be bad because patient will jump and you may cause injury to the nerve. But yes, you check it in the lateral posture. Now you can see in the lateral, we are in the foramen. Yes. थोड़ा सा इसको वो करना, सुन पैरालेक्स हटाना, उधर ले जा. Yeah, check please. Yeah. So now you can see in the lateral view that we are lying very nicely. So I'm going to give the dye in the lateral view only.
So 0.5 cc of this.
0.5 cc of the check please. Yeah. So you can see the dye spreading in the epidural space, and you can outline the nerve over there. Check please. Yeah. So that's the nerve, and now we go in the AP view to check, and then we go in the. No, it is all fluoroscopy. Everything is based on your fluoroscope. So there are no fixed distances like 5 centimeters, 6 centimeters, like in the olden time when we were doing blind. But here we are doing under fluoroscopy, so that whatever you see. So that's the AP, and you can again, you can see beautifully this the dye, the nerve. So this is like this is the best approach. I mean, you can use the infraneural approach, subpedicular, subpedicular. This is the safe Karman triangle. You are outlining the nerve, and the interface between the disc and the root, the dorsal root ganglion, and the interface between the disc and nerve is the important area. So we have targeted that, and now the drug is going in. So similarly, 20 milligram of drug is going in here.
So suppose this needle gets into the nerve, into the substance of the nerve.
No,
how
that
will
will
you
be,
know that?
So that will be the most painful. That's why we don't give lot of analgesics. We don't sort of knock off the patient, because into the nerve is a disaster. So even when you approach the nerve, patient will shout, but into the nerve would be total disaster, because you will cause not lot of injury to the nerve. So that should not happen, and that will not happen if you are controlled in the last few centimeters of going into the foramen. So I put in the drug, 20 milligram, and just flushing the nil with saline and local anesthetic. We put Xylocard, just very minimal amount. Check please. Check. Now you can see the dye has spread nicely, and you can see the root. Okay? Is that okay for everyone? So you have seen L5, you have seen S1, now we go for the L4.
So sir, Xylocard you put after you put in triamcinolone,
Yes,
a little bit.
yes, just about 0.2 ml of Xylocard, because these drugs are irritant, and patient may have pain after the procedure. So just local anesthetic will take care of that pain.
So how much sir you put Xylocard?
ठीक है. Pardon me, sorry?
How much Xylocard sir?
0.2 ml of Xylocard. So I am taking out this needle, and we are going for this final one. Now you check in the AP now. Let's start with the AP view. इसको central करो. So perfect AP. This is perfect AP. The inferior end plate, the superior end plate. Yeah, that's the spinous process. Then these are the two pedicles. Below the pedicle, the lamina. Yeah, the lamina, the pedicle, then the interlaminar space, and then you have the end plates are totally squared. So this is, I am not bothered about the upper one and the lower one. There may be parallax there, but my vertebra where I have to do the procedure has to be squared. And now you can see the foramen. So right, now we are going to turn it little oblique. Slowly and gently please, show it. Shoot please. So now you can see the foramen now.
So obliquity is towards the side you are doing.
Yeah, on the right side, yes. So now you can see the pedicle. Shoot please. Shoot. हाँ. और थोड़ा सा हाँ. थोड़ा और मेरी तरफ करो. Little more lateral. थोड़ा ऊपर करो. Yeah. Shoot please. Shoot. So this looks okay. You can see the Scotty dog, not as good as what you saw in this, but fairly okay. Yeah.
Yes, sir.
This is the pedicle. Now shoot please. Shoot. So shoot please. Shoot. Shoot please. Shoot. 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 Yeah. So that will be my area where I am going to give some local anesthetic. Okay. Any questions?
No, sir, we are good.
You are all mesmerized, no?
Yes, sir.
Very good.
It's a very, very nice demonstration, sir.
And hopefully from Monday onwards or whatever day you reach back home, you are going to do the first case.
Yes, we hope so.
Shoot, please. Check. So I am little off.
How long patient will be pain free, sir?
See, it depends. So it's not the injection which matters. It is the post injection rehabilitation which is important. Check, please. So you have to get a tunnel view.
After some time if pain recurred, you will repeat the injection or you will refer for surgery, sir?
So it all depends, Basically, as I tell, these procedures are very easy to go. But the most important is the post-injection rehabilitation. Like you do post-surgical rehabilitation, the post-injection rehabilitation is also a 3 months job. The posture, the exercises, how to sit and how to stand, till what extent you have to give the drugs, reassurance, psychological reassurance, everything counts. So, I mean, our repeat rate is very low. I mean, we repeat not only more than 30 patients. So, now this is another technique which I wanted to show. I am touching the pedicle. For the beginners, the best technique is this. Touch the pedicle and redirect the needle into the foramen. So, this is touching the pedicle and now I am redirecting. See now. Show please. Yeah. So, redirecting the needle into the foramen after touching the pedicle, safe. So, as soon as you leave the pedicle, you are in the foramen.
So you move it little laterally while on the pedicle.
Yeah, and below the pedicle. Show
below
please.
the pedicle.
Shoot. नहीं pedicle को नीचे आ गया अब मैं ना नीचे आ गया, right? So I am in the AP view now. For the sake of time, I am not going to show you this. This is the AP view, and now we'll shoot in the dye. Yes, shoot please. So this is beautifully done, going into the epidural space. That's the nerve.
Somebody's
and
head is coming in the way of X-ray.
who is coming? Head is coming. My head. Okay, sorry. You roll my head now. Yeah. That's okay.
Yes, perfect.
So you can see the dye going into the epidural space also.
Yes.
Although that's not desirable, but if you have a central canal stenosis, then that is very much desirable because ligamentum flavum is hypertrophied and there is an inflammation there. So the epidural component can take care of that. So if it is a central canal stenosis, along with the root sleeve blocks, I will give an epidural also. But if it is just an isolated disc pressing on the nerve, only root block. So finally, I am giving the remaining 20 milligram of the drug. Okay, and then signing off with this local anesthetic saline mixture, little bit, 0.2 ml.
So,
and
sir,
taking
this
it.
procedure is a transforaminal block or just a root block?
No, everything. This is the terminologies are different. Root sleeve block, transforaminal, selective nerve root block. They all mean the same. So this is over now. If there are any questions till we put the second patient, you can ask me.
Sir, as the root will go just below the pedicle, wouldn't it be safer to target the lower half of the foramen then
Yes,
go up?
definitely. As I said, for the beginners, just below the pedicle is a safe triangle. So you can target that. But if you want to be very safe, the infraneural component is the best one. Infraneural component covers the entire nerve and you have a very good spread and the interface between the disc and the nerve is beautifully covered. So that is preferred. But as a beginner, you may not be able to precisely in a tubular vision go there. So in that case, you can go subpedicular also.
Sir, with this, we are putting two things. One is steroid and second is a local anesthetic around the root, outside the foramen. Am I correct, sir?
Around the root, yes,
outside the foramen.
Yes, I am outside the foramen, but my drug is going inside the foramen.
Okay. Is there any possibility of blocking other roots also because of the spillage into the intraspinal canal?
As
The
you
amount
see
of
here,
drug is very low.
Can you just focus this? If you see here, there is a bit of drug going into the epidural space, but it is going down. So it is going towards the, show that marker. Somebody was showing that marker. Marker जो आया था. दबाना. So, अरे एक marker दबा. अच्छा. So you can see it's going in the epidural space, but as I said, if it is a central canal, it is very good for us. Our target is not the interluminal space. Our target is the root. So if it goes there, no problem. I mean, we are not giving local anesthetic, it is only steroid. And we are doing, this is a dual disc, so no issues. Sometimes you can do 2 routes with one block only. So if you go at L4, you can block the L5 also.
2 things, how you declare your injection as successful, and till how long this effect of pain relief will be expected to him.
See,
because this is not a therapeutic procedure, this is just a pain relieving procedure.
Yeah, this is like a pain relief procedure, but essentially please try to remember this is a curative procedure also, because if the disc is not big enough for the surgeon to operate, and it is the radicular pain which is, there are lots of prostaglandins and other inflammatory mediators which are lying there. So I am sort of nulling them. I am sort of taking care of them. So those inflammatory markers go away with the help of steroids. Patient gets relief. He gets mobility. He starts doing purposeful mobility, activity, and exercises, and everything is okay. So you are giving the disc time to shrink. Not every disc bulge we people operate. So it is giving them time of 2 to 3 months, so that the mobility is there, muscles are strengthened, and the disc retraction takes place.
Actually, the pain relief breaks the vicious cycle.
That also,
and,
of course.
And once the vicious cycle is broken and patient is rehabilitated, many times patient become totally symptom free without any surgery.
Absolutely, absolutely. But having said that, I'll give you an example of my own boss who came to me with a foot drop. I referred the patient to Dr. Kale. I said, no, foot drop, sir, you have to go for surgery. He is 80-year-old. So Dr. Kale said, no, there is no point, the foot drop has already happened, so let us keep it conservative. He came back to me, we did a root block, and to my surprise, after 3 weeks, the foot drop, the EHL was 4/5. So to my surprise. So if it's an immediate insult, which is causing pressure and edema, you can take care of this with the help of steroids. So early the intervention, better the result. In the past, we used to say that more the nerve root irritation, more central sensitization, and more it becomes chronic, more it becomes difficult. So even if you operate a patient after 6 months, the results are not good. But if you do the intervention or even surgery early on, then the results are fantastic. So you may even reverse the motor deficit, although that is not my indication of giving it. But once driven to the wall, patient doesn't want surgery or surgeon doesn't want to operate, you do it and you get the results. Not in every case, but we have seen in number of patients.
Thank you so much, sir. Thank you. It was a very nice